the Western New York network leader / walk chair. And we all know that all types of inflammatory arthritis can cause painful, swollen joints that are hard to ignore, but that chronic inflammation that can affect other parts of the body that you may not expect brings us additional challenges. So we're going to have a guest tonight that'll share tips and guidance on how to keep your whole body healthy and how to stay from other potential arthritis related problems. About me, again, as I stated, my name is Talisa King. I was diagnosed with rheumatoid arthritis in 2012. I currently also facilitate as a co-facilitator for the African American Connect group, and I am the chair for the Walk to Cure Arthritis Buffalo, which will be going into its 8th year. This is a passion for me as it is something that directly affects me every single day. And my goal is just to be here for myself as well as everyone else, kind of help us get some more additional education, talk with the experts tonight, and just see what additional tips and ideas we can get to help us deal with our everyday chronic illness. Okay, tonight's goal is how types of inflammatory arthritis, RA, PSA, AX, XPA, and gout can affect the body head to toe. We'll talk about some of the causes and symptoms of common related diseases and how to reduce the risk. We'll talk about how to identify symptoms of each and what to tell your doctor and which doctors to have on your care team and how to coordinate care between service providers, which is something that's very, very important. And tonight's event program. So we're just going to go over some additional information. All attendees have been muted. Q&A function at the bottom of the screen to type in questions if you chose to. Presentation from our guest tonight, and it'll be followed by a Q&A. There will be a post-event survey if you can just stick around for a moment and do that if possible. youtube.com/arthritis foundation is another place where you can check some things out. Arthritis.org webinars. December 3rd, Living Well with Inflammatory Arthritis will be the next event. And please refer to all the resources for more info on pain management, diet, exercise, etc. Okay, tonight's guest is going to be Dr. Monica Crespo. And Monica Crespo Bosk, MD, is a rheumatologist at Boston Medical Center and an assistant professor of rheumatology at Boston University, Chobanian and Adventitian School of Medicine. Dr. Crespo Bosk has expertise in caring for patients with lupus, rheumatoid arthritis, inflammatory myositis, and other conditions. She is a lead rheumatologist of the multidisciplinary lupus program at BMC. She's also a partner between the departments of rheumatology, dermatology, nephrology, and obstetrics and gynecology. Dr. Crespo Bosk is also an active researcher and a member of the Boston University Arthritis and Autoimmune Diseases Research Center. Dr. Bosk, thanks so much for joining us tonight, and I'll pass it off to you. So I'll just mention briefly a little bit more about why we're here tonight. Again, the inflammatory arthritis, it increases the comorbidity conditions, and I'll let the doc go right into this.
Good evening, everyone. So thank you, Talisa, for the introduction. As you were very well to point out, patients with inflammatory arthritis often will have other medical conditions, what we call comorbid conditions, and there are increased risk of having them. We can go to the next slide to review some of the theories as to why patients with inflammatory arthritis may be more likely to have other chronic conditions. And there's a number of theories that may include things that are related to the condition, related to the increased inflammation and the autoimmune process on its own, but often also related to some medications, particularly when we worry a lot about steroids, so prednisone, and then non-steroidal medications. And then finally, there's a component of lifestyle. And the main things that we worry about in this category will be around metabolic syndrome, diet, exercise, and obesity. And this is one of the really biggest risk factor for many of the other conditions that we'll go over today, with almost a third of our patients also having metabolic syndrome. So we'll go on to cover each of these challenges. We'll start off with the metabolic syndrome and related conditions, which we just touched on. So we'll go to the next slide. So when we talk about metabolic syndrome, which you may have heard of before, we're really talking about this constellation of symptoms that often come together. So patients having high blood pressure, high blood sugar, high cholesterol levels. And this is often in the context of obesity as a big driving factor. And the reason why we care about this is that this really increases the risk of a cardiovascular risk factor. So we worry about heart disease, something like heart attacks and stroke, and type 2 diabetes that really drive long-term complications for patients, including mortality. We won't get a chance to cover all of this in detail, but there is a separate webinar on heart disease and diabetes that you can look up on our website later. Okay, so we'll go over to the next slide. And I just wanted to highlight the relationship between obesity, arthritis, and disability that really contributes and sometimes perpetuates some of these problems. So we know that both arthritis and obesity can impact mobility, and lack of mobility may also be a driver for increased weight and obesity. And there's also this relationship between obesity and increased fat and inflammation. So we know that fat cells at the cellular level drive inflammatory chemicals that in turn can make the arthritis worse or other further down the line complications, including heart disease. Obesity on its own can be a risk factor for some of our conditions, including osteoarthritis, but also in some of our inflammatory arthritis like psoriatic arthritis. And then we can get into this cycle where pain from the arthritis or else for other reasons also leads to poor sleep, poor mood and depression, which in turn makes pain worse. So one thing can lead and sort of feed another. So these are things that really need to be addressed for your overall health. And then we can go to the next slide. Okay, so we'll just touch on some of these conditions that are related to the metabolic syndrome. We'll start off by saying that metabolic syndrome can affect your liver. And essentially, what we see in this condition is that you get fat buildup in the liver and inflammation related to that, which can cause serious liver disease even in patients that are not exposed to alcohol. And this is very strongly correlated with some of the other conditions that we were touching on before. We see it most commonly related in psoriatic arthritis, that's of the inflammatory arthritis, one of the main conditions that we think about when it comes to risk factors related to the metabolic syndrome, but we may also see it in some of our other inflammatory arthritis. A lot of our patients won't have symptoms related to their liver disease or their fatty infiltration in the liver unless they develop very advanced disease. So this is something that often your doctor might catch on routine lab evaluation that they may be doing for the purpose of monitoring your medications or for other reasons. So this is not something that you may necessarily catch on your own. We'll go to the next slide. Okay, so we'll then move on to the kidney. So we touched a little bit about how some of these conditions may be related to the disease itself and some of them to medications. One of the main medications that we worry about when it comes to kidney disease is going to be non-steroidal. So medications like ibuprofen, naproxen, meloxicam, medications that you often are buying on your own over the counter and may not be prescribed, but can cause significant kidney disease over time. So it's important to be aware of it. But there may also be limitations or complications from kidney disease related to the underlying condition. And one of the inflammatory arthritis that we think about the most in this context is gout, where we see gout more commonly in patients with pre-existing kidney disease, but the gout itself and the increased uric acid is a risk factor for worsening kidney function. And in this context, treating the gout and having good control of the disease is going to be important also for your kidneys, not just for your joints. When patients have kidney disease, one of the things that can happen is that it may limit which medications we can use and may limit our options for management. So it's something to be aware of. in both trying to protect your kidneys and the things that you can do to prevent it, and then being aware that the medications we may choose, your doctor might choose for you specifically, maybe in the context of your pre-existing kidney disease and what's safe for that. There are things that we can do to help protect your kidneys, and a lot of it is managing other comorbid conditions, especially hypertension and diabetes. So, good blood pressure control, good diabetes control can help with your kidney health. And then we can go to the next slide. Okay, so we gave you a little bit of a framework of the things that we may see in terms of challenges related to the metabolic syndrome. So now we'll just touch on some of the key strategies that you can use to help prevent some of these. So the first thing to think about is going to be weight management. So even small amount of weight, losing 5 to 10% of the body weight, can have profound implications for your overall health. And we often quote a study that looked at the pressure, how weight affects the pressure on your knees. And losing a pound is you're reducing the pressure on your knees by 4 pounds. So fourfold reduction in how much pressure your knees are feeling, and really can have a big impact in your pain, your mobility, your function. The other thing about weight is that losing weight on its own can help lower the blood pressure, even without additional medications, help decrease your cholesterol, and improve your blood sugars. So it reduces the risk of all the other conditions related to the metabolic syndrome. So it's important to think about how you may be able to lose that weight and talk to your doctor about what options may be right for you. We'll go to the next slide. And then an important aspect of keeping a healthy weight is also going to be diet. And when we talk about to patients about what the right diet is, the focus is really on keeping a balanced diet. There are 4 components that are important as part of this healthy, balanced diet that we are recommending our patients. The first one is prioritizing healthy fats. Second, more plant heavy. We want to lower the sugar and the sodium content on your diet. And finally, doing more whole grains and more complex carbohydrates as opposed to sugar and more processed foods that really we think about as potentially more inflammatory. And then we do need to take into account caloric intake. So we do want to have that healthy diet, healthy balanced diet, but also other components of diet, such as portion size, are going to be important. And there's a separate webinar that will delve into more detail that you can look up online later. The second thing to think about, which is very important, is going to be physical activity and exercise. And we really think about exercise as important as a medication on its own. And that's for a number of reasons. One, that we know that physical activity can help decrease some of the stress hormones that are linked to inflammation. It increases endorphins, which can be sort of natural painkillers, can help with mood, especially when it comes to depression, anxiety, and sleep. It's going to be very valuable for patients. And the important thing is that you want to exercise and you want to do it consistently. But we also are not expecting patients to go from being very inactive and sedentary to running long distances. So a lot of what we do about exercise is trying to think about things that are going to be sustainable and building up a little bit at a time. So start slow. And it really depends on where you're starting off at. So if it means walking more in situations where you would maybe park closer to the entrance, maybe giving yourself a little bit more of a distance, it would mean occasionally taking the stairs instead of the elevator, but it also trying to set up a routine that you feel like you can maintain. So building up to that consistent protected time where you're doing this, 3 to 5 days a week consistently over time, and even small amounts of activity. So increased activity can have an impact. So moving 5 minutes per hour can help improve your heart health. Walking for 5 minutes, 30 minutes after eating can help decrease your blood sugar. So even small changes can have impact. Okay, so we'll move on to our second challenge. And in this challenge, we're going to be discussing some of the things that can be seen. So beyond vanity, skin, nails, hair, and eyes. And we'll start off with hair and nails. And in some of these we will be highlighting how they may be more impacted by one subset of the inflammatory arthritis versus another. So we may see hair loss related to patients that are very sick for a number of reasons. The arthritis may be one of them, but probably one of the more common reasons why we may see hair loss could be related to medications. And that this is something that's worth discussing with your doctor about what if you're worried about this potentially being a side effect, bringing it up and talking about strategies. Methotrexate, for example, has a potential for hair loss, but that's often something that we can prevent or manage by giving you a folic acid supplement, adjusting the dosing or the formulation of it to help with that symptom. Sometimes we need to change medications, but often we're able to manage symptoms with these adjustments. When it comes to nails, we're mostly seeing nail involvement in patients with psoriatic arthritis. It can be very common in psoriatic arthritis. Sometimes it's related to fungal infections, but sometimes it's the disease itself. The same way that it can affect the skin, it can affect the nails, and it can cause pitting or ridging of the nails. So there's some things that we can do to help with that. Some of it may be treating the underlying disease. So as we are treating your psoriatic arthritis and we're giving medications that will help your psoriasis and your joints, often those very same medications will make your nails better. It's just a little bit of a longer process. So it may be delayed as compared to some of the other initial response that you see. And then keeping your nails short, sort of avoiding other irritants to try to minimize trauma can be important. But most of all, a lot of it just takes a little bit longer to respond. Okay, so we'll go to the next slide and we'll touch on skin. And when we're talking about skin, we're primarily thinking about psoriatic arthritis. So most patients with psoriatic arthritis will have psoriasis. Sometimes the psoriasis happens after the arthritis comes. Often the psoriasis will happen before. And then patients might develop plaques or sort of this dry, scaly lesions that can look a little bit different depending on your skin tone. And we have some examples here to the right. About 1 in 3 of the patients with psoriasis will go on to have psoriatic arthritis. So some people only have the skin disease and never have arthritis, but often patients will have both. And that's probably why some of you are here in this webinar. And there's a number of things that can help skin psoriasis better. Some of the things are going to be treatment. So your doctor might prescribe some creams or lotions with steroids that might help with that inflammation. Some patients get sort of light therapy or for the skin. Oftentimes, the medications that you're going to be taking for your psoriatic arthritis are also going to help manage the skin better. So the methotrexate, the biologics. And then a couple of things that are important to recognize is that psoriasis often flares with weight gain. It is very closely related to the metabolic syndrome, as we were talking about before. So we often see improvement with weight loss. And then the other thing that patients find is that stress can be a flare for many of our diseases. So managing that can also be helpful. We'll go to the next one. Vasculitis is a very rare complication. And this is when we have inflammation of the blood vessels. We mostly think about this in rheumatoid arthritis, and this is usually patients that have had rheumatoid arthritis for a very long time. That's often not well controlled. So sort of long-standing, very active, uncontrolled rheumatoid arthritis. And this can be a very serious complication. Patients might first notice a rash, which maybe look like these little dots, red dots, and often in the leg. That's a place it likes to go to, that when you press it, don't go away, and over time may develop open wounds. There are some risk factors associated with it and things that you can do to help prevent it. Smoking is definitely something that we want to avoid. But largely, this is something that as we treat your arthritis, this also should improve, or better yet, we should be able to prevent this altogether. Okay, we'll go to the next slide. So we can see involvement of the eye in inflammatory arthritis, and it can come in a number of flavors. So you can have inflammation of the eye itself, and it can come in two big categories. One is called uveitis, and one is called scleritis. And patients may have either blurry vision, painful eye, or light sensitivity or redness in the eye. The way we manage this is going to be with immunosuppression, so either steroid eye drops or other systemic management such as steroids like prednisone or biologics, for similar to what we would do for the arthritis. Much more commonly, we will see dry eyes. So this is very commonly associated with arthritis. There's a condition called Sjogren's syndrome, which we can see as a comorbidity in about a third of the patients with rheumatoid arthritis. But we can see it across the board in inflammatory arthritis. And this is generally managed with artificial tears, and then follow up with your eye doctors with ophthalmology is going to be important. So if you're finding that you're having any of these symptoms, talk to your doctor. Sometimes it could be related to medication, so they may also review your medication list to see if there's anything else that can be adjusted. Okay, we'll go to the next slide. So we'll move on to our third challenge, which is going to be like this other big category of how the rest of the body may be involved in other conditions related to patients' arthritis. So we'll go to the first one. So we'll very briefly touch on GI disease or gastrointestinal involvement or symptoms. So probably the most common symptom or complaint will be around GERD or reflux. And this can largely be driven by some of the medications that we use. Particularly, we worry about NSAIDs, and patients can have complications such as peptic ulcer disease, so ulcers or bleeding related to NSAID exposure. Within GI, we touched briefly on liver involvement related to the metabolic syndrome. There may be liver involvement for other reasons, and we often, or a little bit more frequently, might see side effects related to some of the medications we use in terms of liver function test abnormalities that may help guide or change your medication treatment. So about 70% of the 70% of the patients with RA are likely to develop GI complications. But this is a big umbrella presentation. So what is done is going to depend on what your symptoms are. But a lot of what you can do sort of on your end is a lot of the minimizing that exposure to NSAIDs. Okay, we'll go to the next one. So separately, there's a condition called inflammatory bowel disease. And this is a different autoimmune disease that can affect the entire GI tract, especially the intestines, and has close association with psoriatic arthritis and axial spondyloarthritis. There's a big category within inflammatory arthritis, which is essentially IBD or inflammatory bowel disease associated arthritis. And these patients with inflammatory bowel disease might present with diarrhea, bloody stools, weight loss, fatigue, and they would need investigation with gastroenterologist and usually an endoscopy to confirm the diagnosis. Some of the medications that we use for treatment of arthritis can also help the inflammation of the GI tract related to IBD, but this is a very important thing to diagnose if patients have it, because some of the medications work for one but not the other. Okay, we'll go to the next one. So one serious complication, though not common, of inflammatory arthritis, particularly rheumatoid arthritis, is going to be interstitial lung disease or ILD. And it's essentially inflammation of the lungs that causes scarring and can make it so that patients are more short of breath, and progressively over time may even require things like oxygen. This is a condition that is managed with immune suppression, and some of the medications that we use for arthritis may be helpful for inflammation in the lungs as well. We're talking relatively small numbers, so we're saying less than 10% of patients with rheumatoid arthritis, even less so in other inflammatory arthritis, will go on to have interstitial lung disease, but it's also an under-recognized condition. So if patients are having more of a chronic cough, they're developing shortness of breath, especially as you're identifying changes in your functional ability. So previously being able to do 2 flights of stairs before getting short of breath, now getting short of breath after just 1. So those types of symptoms are important to recognize and bring it up to your doctor. It could be a number of things. It's very likely something else, but it's something that it's important for your rheumatologist to know, to at least take into consideration whether you may have lung involvement. Risk factors related to this is going to be smoking. So we certainly recommend smoking cessation. This is just another reason to do it. And then, like I mentioned, we manage it with immunosuppression. We'll go to the next slide. Osteoporosis is something that all of our patients need to be aware of. This is very common. 10 million Americans have been diagnosed with osteoporosis, and it essentially means that patients have thinning of their bones, so they have less bone mass, and it makes it more likely for patients to develop fractures. One of the biggest risk factors in the context of inflammatory arthritis is going to be steroid use and exposure. And that means being on steroids, but also how long and how high a dose. So a lot of what we can do to modify this risk, and this is on the physician's side, but also on the patient side, is we really want to avoid steroids as much as we can, and to reduce dosing of steroids if you're on them as soon as we can. Because we know that even small amounts, small doses of steroids, as low as 5 milligrams or less, over a period of years, will inevitably cause thinning of the bones, like osteopenia, which is the milder form or the prior step to osteoporosis, and then osteoporosis. Things to think about to also help minimize your risk: making sure that your vitamin D level is good, and this often requires patients taking supplements. We usually don't get, especially depending on where you're living, you may not get the necessary sun exposure to keep your vitamin D stores where you need them to be. Like I talked about, minimizing steroids. Again, smoking cessation. This is going to be a recurrent theme through this talk. And then sometimes patients may need medication. So once you're diagnosed with osteoporosis, there are medications to help reduce the risk of fractures. Physical activity, exercise is going to be very important for patients with osteoporosis. And this is also important to help prevent falls. So a lot of the complications in osteoporosis come related to fractures. And a lot of what we can do is try to minimize your risk of falls, and exercise and strength training are an important component of that. Okay, go to the next one. Enthesitis is a little bit more closely associated with arthritis itself. So when we're talking about arthritis, as you're all familiar with, we're talking about involvement of the joints. When we talk about enthesitis, it's inflammation where a tendon or a ligament inserts into the bone. So usually it's going to be close to the joint, but not at the joint. And there are many entheses in the body. This we see most commonly with spondyloarthritis and psoriatic arthritis. One of the things that patients might report is developing a big swollen finger, so that looks like a sausage. That's called dactylitis, the sausage finger, and that's a form of the enthesitis. So patients might have pain, stiffness, swelling. So similar presentation and often related to their arthritis. We manage it very similar to how we manage your arthritis. So we may be using immunosuppressive medications such as DMARDs or biologics. We may be using NSAIDs or steroids occasionally. Okay, so wrapping up on our challenges, we touched on how arthritis may be related to many different organ manifestations, and we can't have a talk about general health and arthritis without talking about anxiety, depression, and pain. So we'll just start off here on our next slide. So there's a lot of overlap between inflammation, pain, and depression. And this is an area that's been of a lot of interest in terms of research, trying to better understand what causes what. But we know that patients with chronic inflammation are having all these different cytokines or substances that are released that may also be contributing to pain perception. And that's probably at least a component of why patients with arthritis experience pain. But then it gets a little bit more complicated because there's a relationship between that pain and mood. So the pain can make mood worse, but also poor mood, so depression and anxiety, can make pain worse. And we'll touch a little bit more on the next slide. Okay, so a lot of the strategies as to how to make this better means that we need to target these big categories. So we're targeting the inflammation, we're targeting the mood, we're targeting the pain. And one thing that I am not mentioning here, but is key, is going to be this exercise category. So we know that antidepressants are going to be targeting the different chemicals or neurotransmitters like serotonin and dopamine. And interestingly, a lot of the chemicals that are the imbalances in chemicals that drive depression and anxiety are the same that drive pain. So for that reason, there's good data to support use of antidepressants, not just for the mood, but also for patients with chronic pain. And that is also true within arthritis patients. So your doctor may talk to you about different antidepressants like duloxetine, amitriptyline to help target both of those problems. We're also going to target the inflammation itself. So this is where the disease-modifying drugs come into play. So we may be thinking about biologics, other DMARDs, even non-steroidals that will help improve the pain and the inflammation. And then it's really important to think about sleep and exercise as important components to this imbalance that we see related to pain and mood. So we touched a little bit on exercise before, and I just want to emphasize the importance and its relationship, not just for the metabolic syndrome, for your weight, for your general health, but especially for your mood and pain. So this is going to be a key component to any strategy in targeting and managing chronic pain. And then sleep is going to be often a big driver for or lack of sleep for depression and worsening pain. So really identifying a good routine to help with your sleep, that which can mean better sleep hygiene, having a good routine, a good environment to help to make sure that you're really sleeping through the night and getting good quality sleep and rest is going to be important to get your pain better control. There's a separate webinar again on the connection between inflammation, depression, and pain, so you can learn a little bit more about that on the website. Okay, and then finally, as we're talking about how your arthritis can relate to your general health in so many ways, then it's obvious that it might mean that you will have more than one provider to be part of your care team. And we'll go to the next slide. This is just an example to highlight that you're probably going to have different needs depending on what your disease manifestations are. So all of you will have a rheumatologist who sort of is the central person that will coordinate your arthritis and how it relates to other conditions. But depending on your other comorbidities, like we learned about tonight, you may need other specialists. So patients with metabolic syndrome might be seeing an endocrinologist. If patients have skin involvement, like those with psoriasis, they probably will have a dermatologist. If you have eye involvement, you're probably seeing an eye specialist or ophthalmologist. And then it's important to think about sort of the functional aspect. So physical therapy and occupational therapy being very important additional support depending what your needs are at each time. And this is just, trying to include most things, but your needs may depend on what the disease manifestations are. We'll go to the next slide. And then it's important to recognize that you are an active participant in your own health and that you can help manage some of the coordination in the care. So it can be sometimes overwhelming when you're seeing different providers and there's a lot of complexities in your own care. So identifying what resources are available to you depending on the healthcare setting you're in. There may be nurses and maybe patient navigators and social workers that can help you a little bit with navigating just the system and some of the logistical aspects around it. The use of electronic medical records can make it sometimes easier to reach out to your providers with questions, bringing up issues around sometimes simple things like medication side effects or a need for refills without needing to wait for the next follow-up, which may be months away. And then recognizing that it's important for all your providers to be on the same page, and that may mean, especially if they're within different healthcare systems, making sure that you're sort of authorizing communication of the medical records from one to the other to make sure that everyone is up to date with everything that's going on with your health. Okay. And then just to highlight that a lot of this summer, the purpose is for you to be aware that there may be other things that come up related or unrelated to your arthritis, and your role as your own advocate is to make sure that you're bringing it up to your providers and communicating those so they can help recognize whether this is something more serious that would need additional workup, or at least provide you reassurance if it's something that is not concerning and you don't need to necessarily worry about. And this is not something that falls solely on you because you may not see a direct connection between things, right? So you may not think about your eye pain be related to your ankylosing spondylitis, but your rheumatologist would know that that's a risk factor and something that they would need to worry about. Similar with diarrhea or inflammatory bowel disease and psoriatic arthritis, or shortness of breath and rheumatoid arthritis. So just if you find that you're having a symptom, you're not sure if it's something you need to worry about it or not, your role is just to bring it up to your provider and help them make that decision. Okay. And then this is just to highlight the same point. You want communication with your doctor is going to be key, and it's going to be important both in bringing up new issues, but also in your long-term care, even of your chronic arthritis. So it's important for your providers to know what your challenges are. Are you getting the medication? Are you taking the medication? Are you having side effects? And not, saying something to try to appease us, because our role is really to come up with a plan together that will work for your overall health. And the first thing that we try or the first thing we suggest may not be the right answer for you, even if it works for many other patients. And if you find that you don't have that level of comfort and communication, you always have the option to ask for another opinion. So if you feel like you don't feel that open space, or that things are not going the way that you feel that they should be, you can always speak up and also see someone else if that's what you feel is more appropriate. Okay, and I think with that we'll wrap up. Okay, so I think Talisa will help us with the Q&A.
Yes. Can you hear me okay?
Mm-hmm.
Okay. And I just wanted to say thank you again for all your valuable insight and the information that you gave. We've received several questions before and during the event. We're going to try and get through as many of them as we can, but for the questions that we don't get a chance to answer, I'm going to strongly encourage everybody who's attending the webinar to go to our helpline, and that will be at arthritis.org/helpline, or either visit our library of resources. I also just wanted to briefly acknowledge the fact that we also received a lot of questions beforehand about pain management. So while you'll address some of those questions potentially during the Q&A, I just want people to keep in mind that this webinar is geared towards spotting symptoms of related inflammatory arthritis diseases, and that for more tips about pain management, they can definitely check out our library of resources at arthritis.org/webinars, and sign up for next month's webinar, which is Living Well with Inflammatory Arthritis. And with that said, we will jump right into some of the questions. So your first question, excuse me, is there's a few people on tonight's call that are experiencing nausea with methotrexate. Can you give us some tips for reducing nausea? If you're already splitting the dose, taking folic acid, how do you know if it's from methotrexate or your infusion slash biologic or plaque?
So that's a common challenge we come into, particularly related to methotrexate. So methotrexate will often cause nausea. For some patients, it's mainly the day off or right after. So a lot of the strategies that we recommend are around timing of the dosing. So I often recommend patients take it with dinner or try split dosing. The main thing that can help get away or sort of bypass the GI side effects, especially nausea, is using subcutaneous injection of methotrexate, which can be very effective. You basically are bypassing the whole GI system by using a subcutaneous injection. And usually patients don't have GI side effects in that context. So that may be something worth talking to your doctor about if it's not something you've tried before. And it's usually very inexpensive to get, just like the little vial of the methotrexate, which you can inject yourself with like an insulin needle. So it's much more available alternative to biologics or other medications, and it's often effective. So when patients are having side effects, it's usually one of my strategies will be to go to subcutaneous.
Thank you so much. The next question is, can you advise of the best medication to help prevent osteoporosis? Someone was told that they couldn't take their bone building medication Prolia for more than 10 years.
Yeah, so with osteoporosis management, there's going to be a number of osteoporosis medications, and exactly which one is right for you will very much depend on your clinical context. So you'll have to ask your doctor about specifically for you what is safe to use. Some of the medications are basically used for a period of time, and then you may need to take a break. But that's going to be in communication with your provider. A lot of what you can do ahead of time are some of the things that we highlighted. So making sure you're having good source of vitamin D, which will often mean taking the supplements, and then staying active, working on your core strength and balance, which will help with your bone health and also reduce your risk of falls. And then the third piece will be a communication with your provider if you already have the diagnosis of osteoporosis, to see which of the medications is the right strategy for you. And there's many different factors that play into it, including your other comorbidities, what's available, how regularly you can get some of these medications, some which are infusion and you really can't take a break from or really increase the risk of fracture. So it can be a pretty complex question.
Thank you. How dangerous is it to use a prescribed naproxen sodium daily? What about something like Celebrex? This person has taken both for several years, PRN, and now they're taking Celebrex twice a day.
So we use nonsteroidals very commonly. I think, and in some of our diseases, especially those with axial involvement or inflammatory back involvement, that's our first line therapy. So the short answer of it is that it really depends on the context. We highlight the side effects because we are able to have safer strategies long term for many indications, but not necessarily for all. So we do have patients that are on nonsteroidals for longer periods of time. Sometimes it's particularly safer in patients that are younger, don't have cardiovascular disease comorbidities, don't have a history of prior ulcers, are taking it with food. So there are, certain things that might make it okay to do it for a longer term, and we often use it in our young patients with, like I said, inflammatory back pain. The risk really comes for prolonged cumulative use, especially in those patients that either have renal disease or kidney problems or at a risk of developing it. So the first question is, what are you using it for? And is this something that could potentially be replaced with something safer? So having that conversation with your doctor. Part of the risk is that sometimes that's something that we can all self-medicate ourselves. You can go to the pharmacy and grab it on your end. And we make the false assumption that because you don't need a prescription, it's safer. So just recognizing that it's not necessarily safer than other medications, letting your doctor know what you're actually taking, and they may have recommendations to try to minimize that exposure, even if you do need it.
Okay. Would you be able to talk to us a bit about whether or not RA can cause extremely itchy skin in the mornings and evenings?
So, array specifically, we don't think as much as being causing itchy skin. We can see it with autoimmune diseases in general. We sometimes that's a complaint that patients have. And we also can see it related to some medications. So some of it will depend on the context. So certainly if you are starting to have very itchy skin after a recent change in your medications, you definitely want to bring it up to your doctor if there's any rash associated with it, because some of our medications have pretty high risk of allergic type reactions, some of which can be very severe. So that's one piece. And then sometimes there are reactions in the skin that may not be specific to rheumatoid arthritis or a specific category of inflammatory arthritis, but maybe associated with it. So do bring it up to your doctor, especially if you have a rash, because sometimes they might be able to find a connection with it. I often see patients together with dermatology, and I'll have patients come with a skin condition that looks very inflammatory to me. I don't know what it is and may require a biopsy. A lot of times we are able to come up with strategies around immunosuppression to help those, but they're not super commonly associated with it in a way that we can just out of the gate say, oh, this is psoriasis related to your psoriatic arthritis, for example.
And the next question is something that in my early years of my diagnosis, I can definitely relate to. Fortunately, over time and self-advocacy and just learning what that looks like, I've been able to kind of mitigate it. But what would you suggest as the best course of action when your rheumatologist or any doctor on your team refuses to communicate or play nice with other doctors? It's really hard to switch rheumatologists, especially depending on where you are.
Mhm.
Can you advise of what the title of a professional is who can oversee care in complex conditions?
Yes, so coordination of care can be challenging, and a lot of it is going to be largely impacted by where you are and what is available to you. So within, access, the ideal scenario and what I often recommend patients is to try to stay within a system. And part of it is that even if there's imperfect communication, at least you have the insurance that they're able to see each other's documentation, right? So each time you see your doctor, they're going to write down their thoughts. And even if they don't talk directly to the other doctor, when I see you in the clinic, I can see, oh, last month when you saw your lung doctor, they thought your lungs were doing well and didn't want to make changes. But I also recognize that's not universally accessible. But if you have the choice, people that are within a medical system, a medical record system, something that communicates in some shape or form. The other piece is making sure you are able to get some of the access yourself. So a lot of the medical record platforms, you're able to create a user and you're able to get basically all of your records on your phone and your computer. And this is something that you can carry with you from visit to visit. So when I'm seeing patients that may be outside of my system, sometimes I can't see, for example, blood tests that they had done before, but they're able to show me on their own phone to tell me, oh, I had this done last week. This is what it shows. So at least you can help bridge some of those gaps. And then the third thing is, which I think is key regardless, is a good primary care provider that really plays that coordination role. That is usually going to be that central piece and is very valuable to have a good primary care provider that really is overseeing all of your care. What I see happen often is that patients will keep seeing their rheumatologist and then don't really follow up with their primary care as often. And then we miss things because we're not doing the routine screening for your cancer screening for your colonoscopy, or we're not thinking regularly about your cholesterol and other things that are really important for your general health. So just recognizing that even if you think your only problem is arthritis, you will always need that additional communication and that additional provider, and a good primary care provider can really help facilitate a lot of those things.
So would you suggest that people, you said the user ID, so I'm assuming you're referring to like portal systems that different medical offices and doctors have?
Yeah, so it is very helpful when there's lag in us getting records of some sort or being able to reach your provider when patients are able to bridge that for us. And oftentimes, if you create your user in whatever platform they're using, you have it sort of on you at all times, the your medical records. So you're able to look back and see, oh, I saw so and so 2 months ago and they ordered these labs. With, by law, you have access to your full medical record, right? You can request, depending on the setup. Sometimes you have to request hard copies, but most places have migrated to records that you can access remotely, and you can see every note that is written by your provider. So that can be helpful for your general information, but it's very valuable for your providers to help bridge if that communication fails.
And lastly to that, with you being a doctor, can you confirm, because it's something I've been curious about, so I'm sure other people have, if you sign a release for a particular doctor like yourself, giving access to your records to other medical providers or vice versa, does that automatically mean that you receive that information, or is that something that would still need to be requested?
It's imperfect. So part of the challenge with medical record transmission is that it's very old school. So a lot of this communication is still done by fax. So essentially you fill out this form, which often means someone from my office sends a fax to someone from their office. And at some point, if they respond like they should, they'll send a fax back with some information, which may include all the records, some of the records. It's variable. And even if we get it, it's that time point, right? So it doesn't necessarily mean that when they see you 3 months from now, 6 months from now, they will also communicate with me. It just says that you give permission for them to do so, but it is challenging, and a lot of times we need to sort of revisit that.
Okay.
And depending on the staffing of your provider, they may or may not have the resources to keep following up regularly like they should, or some of it ends up also becoming more burdensome of the patient's side to keep requesting. So it's definitely a challenge.
Thank you for that. What can manage enthesitis naturally?
So with enthesitis, one of the things that we recommend to our patients is going to be around stretching and exercising, and that can be very helpful, depending on the location that's involved. Short of that, it usually requires medication and immunosuppression to make it better, especially if it's sort of more of a recurrent or chronic issue, because that can be pretty, limiting, painful, disabling in cases. But short of medication, exercises to help preserve range of motion is going to be important.
There's two people that chatted in that they have asthma and one has lung nodules. How worried should they be about ILD?
So ILD is relatively rare. If they've been having monitoring for other respiratory symptoms, a lot of it is going to be similar to what they would do to identify the interstitial lung disease. So for example, in asthma, they may be doing pulmonary function test at some interval. When they do the pulmonary function test, they basically have you do all these exercises where you blow very hard. They measure how much air comes in and out of your lungs or your mouth, and they're able to recognize different categories of problems on your lungs. So with those tests, they're able to, the way that ILD behaves is very different to the way that asthma behaves. So that would be a way that if you're getting monitoring for the asthma, if you're getting those lung function tests, they would see that. That's different. And then with the lung nodules, similarly, they're doing imaging, right? So when you do, for example, a CT scan of your chest, they're looking at your lungs the same way that they saw little spots, which is nodules. They would be able to see like a pattern of scarring in the interstitial lung disease. So if they saw the nodules, they didn't see the scarring, that's probably pretty reassuring. They often will be doing additional imaging over time to follow up the nodules, so they would probably identify if there was any other scarring along with it.
Okay. Does entering perimenopause/menopause exacerbate symptoms of inflammatory arthritis, specifically PSA?
So menopause and perimenopause it's an interesting period because we very commonly see joint pains generally, even in the absence of patients having inflammatory arthritis like psoriatic arthritis before. So it is possible, even potentially likely, that you'll have some additional aches and pains in that context. We don't necessarily expect your psoriatic arthritis to be more active, meaning your joints to get more swollen, your skin to get more involved, more rashes, but patients might have a little bit more pain. The relationship between pain and arthritis is a tricky one, right? So, when arthritis is active, you will likely have pain. But a lot of time patients have pain even without active arthritis. And I think that sort of menopause, perimenopause, or medications that cause similar effects, like some of the medications that people take, for example, with breast cancer, that induce chemically menopause, patients are likely to have joint pains, but usually not swelling with it.
Okay. Will an earlier diagnosis of fibromyalgia before RA mean you are less responsive to RA meds?
So fibromyalgia and RA very commonly coexist, and sometimes people are initially diagnosed with fibromyalgia and then go on to show clear inflammatory arthritis. Sometimes it comes later. And basically what it means is that you're more likely to have pain symptoms with or without the active arthritis. So patients with, for example, rheumatoid arthritis, just to say one, are probably equally likely to respond to the inflammation, like the visibly swollen joints that we examine when we see you in the clinic, to the different medications. But possibly the patients might, their experience might be different, right? So patients that have fibromyalgia, which is active, find things that shouldn't be painful, right? So sometimes it's soft touch or even a hug is painful. So we see a similar pattern with the joints. The joints might hurt more even when your doctor says your arthritis looks really good, the medicine is working, but you're still feeling like you're having pain. And a lot of what we try to teach patients is distinguishing, this is my arthritis pain, this is my fibromyalgia pain. And it's really important to know the difference because the strategies are different, right? If I think your rheumatoid arthritis is still active, I'm thinking about changing your medication, your biologic medications, giving you more immunosuppression. None of those strategies are going to be helpful if it's fibromyalgia, and it's going to expose you to additional risk. So if the problem is fibromyalgia, our strategies are around exercise, sleep, mood, potentially antidepressants. So strategies for coping with the pain that are not going to increase your risk of infection, for example.
That is a perfect segue into our next, what I consider $1 million question. I think it's something that people with all forms of arthritis struggle with, which is how do you decide if the risks for associated with getting steroids for a flare-up are worth it?
That is a very tricky question. So I will start off by saying that we hate steroids. Steroids are poison, okay? So, but sometimes that's the only thing that's going to work fast enough, okay? So the main message with steroids, and I have patients that love steroids, right? Because they make you feel better. So if there's one thing that you know is that if you take prednisone however much, in the next day, you'll notice a difference. If I do anything else in terms of changing your medication, you're not going to feel different the next day. It's going to take us weeks to months. But it comes at a cost, and that cost means that patients are more likely to have osteoporosis, diabetes, obesity, heart disease. So it's a very high cost, especially when we're talking about something that's a chronic disease where maybe you were diagnosed when you were 22 and you'll have it for the next 70 years of your life. So how many prednisone tapers could that be? So we really need to be very cautious about how we use it and when we use it. And that has to be a conversation with your doctor, and it comes to that balance. So I fall in the category of the doctor that's very apprehensive to use steroids, and I really minimize and try to convince patients to get away with as little as possible. And there's patients that feel very much the same. They're like, I don't want to take steroids, even when you feel like, oh, you need them, you're really being disabled by how inflamed your joints are. So it's a lot of a shared decision making, but recognize that each time we're giving you steroids, that dose is accumulating and we're really increasing your risk, maybe not for the next year, but in the next 10, 20 years, it makes a big difference.
It's what I like to call the gift and the curse, because you're right, it gives that immediate resolve, but long term, if you're not on it and off of it, it's all of the extra things that you have to deal with.
Yeah.
Which leads me into my next question. How can you tell if your problems are from the medication or from your disease?
Yeah, so that can be tricky. So a common problem that we come up with is that, well, sometimes patients don't know what's going on. Sometimes patients assume it's the medication, and that's a very common issue, right? We like to blame something external to us, and the medication usually gets the bad rap for it. So for the most part, I think the universal advice in this category is always at your doctor. You're like, I am having headaches, or I am gaining weight. These are like very common things that I get asked about. Or I'm having nausea or diarrhea. Could it be my medication, or could it be something else? And there are times where we really can't tell unless we stop or pause the medication. But there are times where your doctor might be able to tell you, you know what, this is not, I've never seen this. I looked it up. It's never been reported. It's very unlikely that this is related to your medication. Or, yes, we see this sometimes. Let's try with these strategies. Sometimes it's, like GI symptoms, like we mentioned, could be the medication. It could be that you have diarrhea because you also have another autoimmune disease affecting your GI tract. So there is not one right answer. So the main thing is just be aware of your symptoms, keep track of what's happening with your body, yourself, and any changes in pattern, and then bring it up to someone that's seen a lot of patients like you on the same medications that you are, so can have a better sense as to how likely it is to be one or the other.
Can you explain what tumor necrosis factor is in RA?
So the TNF is a chemical that's related to inflammation, and it's one of the chemicals that is targeted by some of the biologics. So the first category of biologics, or the injectable antibody medications that we use in rheumatoid arthritis, targeted the TNF, and they're called TNF inhibitors, and there's a number of them. Many of you may be on them, like Enbrel, Humira, Simponi, Cimzia. All of these are injection medications that target the TNF. And basically, it's one of the pathways that we know are related to inflammation in RA, but there's others. So the different other biologics target other inflammatory cytokines related in other pathways that also lead to inflammation of the joints.
When your rheumatologist says your fibro is a neurologist issue to deal with, but several neurologists you've been to say it's a rheumy issue because it's attached to your RA, what do you do?
Yeah, so fibromyalgia is a tricky one. So the main role of the rheumatologist related to fibromyalgia is recognizing or ruling out whether there is also an autoimmune disease. So fibromyalgia is more of a pain syndrome. So it means that your nerves are basically sort of wired up, and your body senses the input that shouldn't be painful and tells your brain that there's something painful. So a lot of the strategies that we have to manage fibromyalgia are similar strategies that we use across the board for chronic pain and pain syndromes, which is not targeting autoimmune disease or using things that decrease your immune system. So classically, rheumatologists don't specifically manage fibromyalgia, mainly because we don't have additional tools to help with that. But we do see it in combination with inflammatory arthritis quite often. So we will often sort of borrow other resources, and that might mean, connecting you with neurology or pain medicine for other strategies that they have on their toolbox to help with pain that we may not have, or connecting you with psychiatry, psychology, social work for additional resources because it is very multifactorial. So it's sort of a different entity than the arthritis itself, and it's a way of getting you to the right resources essentially.
Okay. And our last question of the night is something that is very near and dear to my heart, as I have experienced this as well. It's not an easy one. So I'll ask the question. I'll kind of throw in a few things that kind of help me work through it. But then your expert advice following up for that would be absolutely amazing to kind of end this up for tonight. So the last question is, a viewer shared that she's been going through a lot of health problems that are in line with inflammatory arthritis diagnosis. She's been on numerous medications, nothing has worked, and she hasn't received a diagnosis from her doctor. Her question is there a way to find some light at the end of this long tunnel of pain and frustration? And I can definitely relate, as I went almost 2 years before I received my official diagnosis. And I know for me, it was definitely journaling and tracking, like my signs, my symptoms, who I saw, the things that they said. It is definitely mentally not an easy thing to get through. Doing some research on my own and just basically staying diligent. I know for me, the biggest thing in the beginning is, just as much as what turns out to be a physical condition, it is very much mental. So being able to have a strong support system and being able to, just kind of not feel completely defeated all the time and just staying the course. So for me, it was going through a whole lot of neurological stuff and then finally being able to get to where I could see rheumatology, because the health insurance companies can sometimes become a barrier as well. So those are kind of like a few things that I was able to use. Of course, every day was not perfect for me, just being able to press through and not feeling away. But if you could also offer some insight to how she or he could work through this tunnel of pain and frustration.
Yeah, so it's a combination of things, and it's a complicated question because sometimes the issue is, the delay to being able to find the label or the diagnosis. Sometimes is even having that label or diagnosis, getting the control that you need or want, and sometimes going through multiple sequential treatments that you're offered hope that will be helpful and has been helpful for other people but not for you, and then just life, just dealing with everything else that continues to happen as you wait the 2 to 3 month window for the next medication to work. So some of it is also giving yourself room to sort of forgive yourself a little bit, and recognizing that it is a big burden, that it's a process. And some people find that through support groups, through family members, just recognizing the need to share the burden and have others, and looking for what version of that works for you is important. Vocalizing what your needs and challenges are, and that might be at the visit with your provider. That sometimes might mean that you need to, see people more frequently, that you may need to send messages, or you may need to ask for another opinion. And so it really depends on the scenario, but a lot of it comes from trust. So finding a person that you feel comfortable in terms of a provider to go through that process, recognizing that it may not be a quick solution, and if it's someone that you trust, they'll upfront sort of set those expectations of, this is what we're going to do, this is what I'm hoping will happen, by this time we'll have a better sense. So it's not an easy process, but recognizing the need for additional support. For other conditions, I see a lot of lupus patients, for example. We've recognized the need of, mental health as a big part of the burden of what our patients are seeing. So we've been able to, engage mental health provider. We have a psychologist in our clinic that helps see some of our patients. So there may be things that are part of your care, and sometimes you just have to seek it out through and sort of bridge on your own to find all those other supports that are part of the equation.
Thank you so much. And again, thank you, Dr. Crespo, for joining us tonight.
Thank you so
Personally, for
much.
me, I've learned so much, and I'm looking forward to applying some of this knowledge to keeping myself healthy. Especially, we talked about the various challenges. We talked about depression and pain, the advocacy, which is very, very big, and just kind of getting that extra to stand up for yourself and consistently be there, realizing that some days you may feel a lot stronger with doing that than others, and definitely giving yourself that grace on the days that you don't, or you don't feel that way. Managing your team, all of that is great information and definitely great advice. So if anyone has any questions to kind of help better understand your disease, interpret insurance coverage, to connect with other people, or to get involved, you can definitely reach out to our helpline number, or either the helpline at arthritis.org is also a online option for you to be able to do so. So for upcoming webinars, as we mentioned before, the foundation definitely offers free webinars every month that's hosted by nationally recognized leaders in our care. So the upcoming webinars include Living Well with Inflammatory, and that'll be on December 3rd. You'll learn how inflammatory arthritis impacts your body and the ways that you can treat it. And you'll also get a refresher on the best self-management strategies for inflammatory arthritis. The other is reframing OA. And for that, osteoarthritis is more than just wear and tear. In that webinar, they'll kind of discuss the root causes of OA, treatment options, and the power of personalized care. Additional resources: you can learn more about your diagnosis and how to stay fit at the sites that are listed here below. There's a link for health and wellness, ebooks, the podcast, and yes tools, all of which are things that you can kind of, peruse around in your spare time and just kind of take a look in there. But it's some really good resources. And my absolute favorite, upcoming virtual Connect group events. So the upcoming events that we're going to have are going to be the rheumatoid arthritis group, which is 11/23 at 12, which will discuss holiday hacks. And then chronic pain group will also be on 11/25 at 6 p.m. And those groups are a great way to get support and learn more about positive coping strategies to manage. And some meet in person, some meet online, but definitely for being able to connect to those and other groups, go to connectgroups.arthritis.org. Also, shameless plug, there is not a limit to how many groups you can join. Typically with scheduling, they don't overlap, and if they do, it is not by much. So definitely go to connectgroups.arthritis.org and see what groups apply to you, or groups that you would like to gain more information about. And in a few days, you'll receive a survey asking about your experience. Please, please, please take the time to fill out the survey and complete it honestly so that we can better serve you in the future, just making sure that we are able to tend to your needs and give you information that is definitely useful to you and the masses. And you can join us next time on recordings. Arthritis.org/webinars will be for previous webinars as well as upcoming webinars. And lastly, I would like to say thank you to our sponsors, Novo Nordisk, Amgen, and Bristol Myers Squibb, for providing the support to make this event possible tonight. And thanks again so much to everybody for joining us tonight. Take care and have a good night.